So the next talk is by Katherine Young, and she's going to discuss precision medicine and type 2 diabetes, predictors of differential hemoglobin A1C, response to SGLT2 inhibitors, identified in primary care data, and replicated in the, excuse me, the EMPA-REG outcome trial data. Katherine from the University of Exeter. Katherine, please go forward.
Thank you. So yes, I'm going to talk about predictors of glycemic response to SGLT2 inhibitors. So as an introduction, so for most people with type 2 diabetes, after diet and lifestyle interventions, they're prescribed metformin as their first-line treatment. And if or when this fails to adequately control blood glucose levels, there are a number of different classes of medication which can be prescribed as a second-line treatment. And at the individual level, responses to these different medications appears to vary greatly. So given this, we aim to identify simple clinical characteristics which robustly predict glycemic response, and so could be used to optimize second-line treatment choice for an individual. And my work is focused on looking at SGLT2 inhibitors. So in order to robustly identify clinical factors which predict response to SGLT2 inhibitors, we use a two-stage framework. So in the first stage, discovery analysis in routine primary care data, we use the UK Clinical Practice Research Data Link to identify patients who are newly initiating SGLT2 inhibitor treatment. We extract their baseline routine clinical features and extract their HbA1c after 6 months of treatment, which we use as a measure of glycemic response. We can then carry out regression analysis to see whether any of these baseline features are associated with glycemic response. And the advantages of doing stage 1 in primary care data is you get these very large sample sizes that you can see here. It's a representative type 2 diabetes population, but the issue is that patients are not randomized to their treatment, and this can introduce confounding or bias, which we address in stage 2. So here we verify the results in clinical trial data, in this case EMPA-REG outcome, in which patients are randomized to their treatment. So we know that if the clinical features which were identified as predictors of response in stage 1 are also predictors of response in this population, that they're not due to confounding or bias. So here I show the results from stage 1 of this process. So on this plot, points on the left indicate that a higher level of this feature is associated with a better response to the medication, and on the right that a higher level of this feature is associated with a worse response to the medication. So you can see here that some features such as albumin level don't differentially predict response to SGLT2 and DPP4 inhibitors, so they wouldn't be useful for identifying patients who would respond better to one of these treatments than the other. You can see for eGFR, which is a measure of kidney function, and ALT, which is an enzyme produced by the liver, that higher levels predict much better response to SGLT2 inhibitors, but don't show the same response to DPP4 inhibitors, so could be used to help guide treatment choice. And when I repeated this analysis in the EMPA-REG outcome data, you can see that the results are replicated really well, despite this being a slightly different population. And that suggests that these associations are robust and not due to confounding. So in summary, I've presented this two-stage framework for use in precision medicine, which we can use to robustly identify clinical features which predict response to a specific therapy. I've shown that eGFR and ALT predict glycemic response to SGLT2 inhibitors, but not DPP4 inhibitors, so could be used to inform treatment choice for an individual. And just to say that this two-stage framework could be used for a range of endpoints, not just glycemic response, as I've shown here, and different precision medicine approaches. Thank you, and I'd be happy to take any questions.
Okay, Katie, thank you. Drop your slide set if you could, please. All right, well, one question comes up. By the way, people are not asking questions, so use the chat room to address the speaker with questions that you might have. One thought that I had in looking at these data, first of all, the replication is beautiful. So it's nice to see one data set replicated by a second one. Validation is always so important. But the question I had, why might people with modified eGFR or higher levels of ALT, presumably reflective of non-alcoholic fatty liver disease, have a better response? What are your thoughts? Let's think pharmacologically now.
Yeah, so I'm really not sure about ALT. I think for eGFR, what we're seeing is that people who have a normal kidney function, so an eGFR of 90 or over, respond better to these treatments. And that could be because they're clearing them differently. I'm not, and it could be the link with the liver as well, perhaps due to the clearing of the drug. But yeah, I'm not sure. And obviously, specifically with SGLT2s, they do, you know, act in the kidney. But yeah, I'm not sure exactly what the clinical explanation is.
All right, good. Well, several questions were directed towards the liver. Do you have any thoughts about ALT, presumably representative of non-alcoholic fatty liver disease?
It presumably is, and it's the higher levels, it's the kind of above normal clinical levels that are associated for that. But again, I don't know, so I'll be interested in any kind of clinicians' possible explanations for that. But yeah, these are relatively new results, so we haven't really investigated that yet.
Well, congratulations on very nice work.